Triceps tendinopathy, rare but real. What is it? Who are the presentations of patients that show up with it in the clinic, and how can we help these individuals? So let's talk about the context. Let's talk about the prevalence of this. You may have never seen a case of this, or maybe you had a suspected case of this, weren't really sure what was going on, how to diagnose this. Maybe patient got better and you never really had to figure out what was really going on. Or maybe you see a lot of this and you're not sure how to help these individuals really well. We're going to talk about how to diagnose it. What are the diagnostic criteria for triceps tendinopathy? And then we're going to talk about treatment. So let's talk about the context and the background first. Is this a real thing? Yes, it is a real thing. Triceps tendinopathy is indeed real. It has a very low prevalence, though, 3.8%. What does that number mean with any sort of context? Comparatively, Achilles tendinopathy, which we're all very familiar with seeing, diagnosing, and treating, has a 6 to 17% prevalence in recreational runners, 24 to 28% in competitive runners, and 10% in gymnasts. So folks who are encountering a lot of plyometric load to that Achilles tendon. Across all sports, all professions, all exercise modalities, Achilles tendinopathy accounts for 20% of all tendon-based injuries. So that is a very, very, very prevalent condition. And that lets us know that comparatively to triceps, 3.8% is very low, especially compared to those competitive runners, 6 to 7 times less likely to see somebody walk in the door with a triceps tendon injury. Now, how do we diagnose this? How do we know what's going on? How do we delineate this from maybe medial or lateral elbow tendinopathy? And we have some very specific diagnostic criteria here, which are helpful. The main two are age and gender. Almost exclusively, this happens in men over the age of 40, specifically twice as often in men, and then much more prevalent in men who are over the age of 40. These folks are doing repetitive elbow extension. Obviously, something is overloading the tricep, but think of someone who is working a hammer, right? Maybe a Finnish carpenter or something like that. Maybe someone working a jackhammer, encountering that plyometric elbow extension, elbow flexion at work all day long. Somebody who's maybe rolling paint, especially overhead, tall ceilings, something like that, where they are repetitively and forcefully extending the elbow. And then we see it in sport as well. Not too common. Again, it does have a low prevalence, but think about a football quarterback, high velocity throw, elbow extension. Think about our linemen, offense and defense, who are tackling in that horizontal press motion. And then their training is also going to be reflective of the likelihood that they could develop this condition. Think about doing a lot of bench press, right? Horizontal pressing, a lot of forceful, high velocity elbow extension under load. And then our Olympic weightlifters getting underneath of a jerk, vertical pressing, but still forceful elbow extension, and then a snatch. Same thing, locking out that snatch overhead, getting underneath of that barbell, and aggressively performing elbow extension under heavy loads and high speeds. These folks may or may not have something that is known as an olecranon traction spur. We can obviously not diagnose this just with our eyeballs, but there are some subjective and objective things we can look for. Can this person mimic a front rack position? So can they supinate their arm? If you're on the podcast, you can't see anything. I'll explain what I'm doing. I'm going to bend my elbow to 90 degrees. I'm going to supinate my hand. I'm going to reach my fingertips towards my anterior delt, and I'm basically going to bring my elbow up to 90 degrees, what we might call the front rack position. And then we can palpate. We can palpate between the two tendinous attachments of tricep at the olecranon, and we can feel that groove. Now, in a normal tricep tendon, it should feel smooth. It should feel like muscle and tendon anywhere else in the body. When these folks develop this traction spur, this can feel swollen, hot. It can feel grindy, poppy. And in later stages of tricep tendinopathy, if we really start to get some spurring happening, that person may not even be able to tolerate that position. Bending their elbow to that degree is trying to stretch a tendon that at this point has begun to calcify. And so it no longer has that nice collagen matrix where it stretches and elongates. it feels like trying to bend a bone, which is not comfortable. And so just seeing how that position feels, how that palpation feels, subjective reports, this person may explain that it always feels swollen or inflamed, even if objectively measuring it with a measuring tape or something like that reveals no difference side to side. Again, it's happening inside the joint. It's happening where the tendon attaches to the olecranon at the elbow, and it has begun to calcify. Why do we care about this? We can't see it with our eyeballs. We can't do anything about it surgically. So why do we care? We just need to know that if this person has a traction spur going on, it's not impossible that they'll do well with rehab, but we have to understand, again, the tendon is calcifying at this point. And so bones do respond to load, but we can't expect to lengthen a bony attachment that is supposed to be tendinous. It just is not going to respond as fast or probably as well as we would expect with any other sort of tendon-based treatment. Not to say if that's there, you just kick that person out straight to surgery, but in the back of your mind, you should be thinking, if I don't see the results I want, I shouldn't be surprised. Now, subjectively, I would say these folks present in two different buckets. The first is far and away going to be the most common. It's going to match the diagnostic criteria. This is going to be that old, stiff male, right? This person who's over 40, probably in their 40s, 50s, maybe 60s, obviously still active, encountering a tendinopathy injury, a volume management-based injury. This is going to be every person you've ever seen in the gym that does pull-ups and overhead pressing while maintaining a nice elbow bend the whole time. They never fully flex and they never fully extend their elbow. Why? Especially in the case of tricep tendinopathy, especially if they have spurring going on, it's painful for that elbow to reach full extension, and so they stay out of there. Why is that bad? Well, we never want to see partial range of motion. We know we're now displacing load across less surface area. I like to explain to patients, why am I so fanatical about restoring your range of motion? It's a lot like rotating your tires. If you rotate your tires every 5,000 to 10,000 miles, you can get 100,000 miles out of them, right? The insides wear down, you put them to the back, they become the outside, you get even wear across the tread of the tire. You can really extend the life of your tire. If you never rotate your tires, you might not get 50,000 miles out of them. And so the more we can restore range of motion with these patients, the more we can disperse load across the entire tendon, the better they'll feel, the faster they'll heal, the stronger they will be able to get. But because these people lack that full range of motion, they are never fully bending or extending the elbow, which means they are overloading through a small range of motion when they're doing things like bench press, jerk, snatch, throwing, whatever they might be doing. These are almost all of the folks who are going to present. They may present the opposite way. We won't talk about that today, but obviously you can imagine if they can't fully flex, they hang out in a bent elbow with pulling, like pull-ups and muscle-ups and that sort of stuff. They can present with some biceps tendinopathy for the same but opposite reason. Now, the second bucket of folks we pretty much never see. This is the young and mobile person, not necessarily a female, sometimes a male, but overwhelmingly female. Why? These folks have the ability, they have strong legs, strong core. They have the ability to generate momentum through things like kipping, the dip and drive mechanic with vertical pressing for a push press or a jerk. That basically they have the ability to create momentum with their lower body and core to bypass a weak deltoid and get weight over their head or on their hands if they're doing handstand push-ups, more volume, more weight than they would be able to normally lift if they were doing maybe a strict press or strict handstand push-ups. And so they are able to use that momentum to maybe get sets of 3 to 5 kipping handstand push-ups, to do a bunch of push press or a bunch of jerks and a Metcon where they would never be able to lift that weight as a strict press or at that volume. These folks typically use CrossFit or otherwise weight training is cross training. And I would say stereotypically, these individuals are maybe doing a lot of running, a lot of biking, Peloton, yoga, Pilates, whatever. These folks typically don't show up on our caseload, but they are out there. Why don't they show up? They are young, healthy, and active, so their symptoms maybe tend to clear up before they consider getting care. If they continue doing this and get through their symptoms and they continue to lift weights, they are going to get stronger, right? So they're going to get stronger delts, which is going to help them withstand more volume. They're going to build their tissue capacity. Or sometimes, unfortunately, these folks self-select out of whatever they're doing. Because it hurts, because they're already doing mostly something else, they decide to just drop the CrossFit, the bench press, the weightlifting in the gym a couple days a week, whatever they're doing, which is unfortunate, but it does happen. But these folks are out there, and I would say these folks are as fun to help as the old stiff males, right? Because if they can just get on a program where they're doing 2 to 3 days a week, a 10 to 15 minute remom of some handstand holds and some plank shoulder taps and some delt and pec strength work, they will not only respond well symptom-wise, but they will respond well performance-wise, and they will love you because now lifting in the gym feels a lot easier, it feels a lot better, and obviously it's not symptomatic, and they're going to love you for that. So old and stiff versus young and mobile. Now let's talk about what does treatment look like for these individuals. Before I do, I'm going to pause and introduce myself. My name is Alan. I'm happy to be here on Fitness Athlete Friday. I have the pleasure of teaching in our Fitness Athlete division. I teach our Level 1 online course. Our next cohort starts March 23rd, which is just a couple weeks away. That is 8 weeks online. It is synchronous, which means you interact with us on the instructor team, not a self-study course. This is an entry-level course, so whether you have never done CrossFit, you've never done weightlifting, you're just dipping your toe in the water, or you've been doing it for a while, there's something for everybody. We take you through all the foundational movements, all of the lecture material and research to support those movements, to support high-intensity exercise in the clinic, both with athletes and with your quote-unquote normal patients, and we have a fun time across 8 weeks. We also have our Fitness Athlete Live course, a couple courses you can get into coming up March 22nd and 23rd, so next weekend. That will be down in Claremore, Oklahoma with Mitch Babcock. April 5th and 6th, Joe Hanesco will be out in Windsor, Colorado. That's the Fort Collins area. And in the weekend of May 17th and 18th, you have 2 chances, either with Mitch again down in Fortville, Indiana, or with Joe again out in Grand Rapids, Michigan. Okay, treating these folks. Obviously, top of the list, if they're symptomatic, is going to be symptom management. Everything helps here. Elbow joint mobilizations, especially for that old stiff patient to restore full range of motion. If you're not comfortable with those, take our extremity management course. Dry needling to the triceps around the elbow. Take our dry needling course, another plug. Whatever you can do, scraping, cupping, voodoo flossing. A lot of folks with that old stiff presentation love a heavy band wrapped around their elbow, move that elbow through as much range of motion as they have. A lot of folks report it's going to help with that feeling of swelling or inflammation that they have. It's going to allow them to maybe do their PT homework, allow them to do their exercise routine, whatever. And then isometrics can be really beneficial here as well. Even something as simple as a plank, right? Try to show me as much elbow extension as you can and then hold a plank. That's going to load that tendon. That's going to challenge that range of motion, especially if the patient's irritability is very high. And then we do need to get into restoring range of motion, likely maybe with eccentrics, a lot of time under tension, especially for that old stiff patient. And then both old and stiff and young and mobile need strengthening. They need to strengthen through the range of motion they've been bypassing if they're the old and stiff bucket, and they need to just get stronger in general in the young and mobile bucket, get those delts stronger so the tricep stops taking too much of the load. Time under tension is our friend here, both for the deltoid and for the tricep complex. So think about something like a landmine press. If vertical pressing is painful, these folks can often tolerate a landmine press, but tempo, right? Time under tension. Press it up. 1, 2, 3, back down. I love to give out 5 sets of 5 at a 3-3-3-1 tempo. 3 seconds up, 3-second pause at that end range, especially that old stiff person, cueing them. Lock that elbow, punch the ceiling, cues to encourage elbow extension, 3-second hold there, and then a 3-second lower back down to the shoulder. things like push-ups, again, especially tempo push-ups, things like deficit push-ups if the individual has the strength, working a deeper range of motion of the elbow, really getting into deep elbow flexion, deep elbow extension at the top, again, encouraging loading across a very large range of motion. My personal favorite is to encourage both groups, both buckets of patients, to use a dip and drive with a dumbbell or a barbell to push press or maybe even jerk weight overhead, and then control the lowering eccentrically back down to the shoulder. That's going to get a lot of things. That's going to let us lift more weight than we could strict press. It's probably not going to be symptomatic because we get to use so much momentum from our legs, but it's going to let us lift more load for more time under tension, but with less volume. There, we might only have to do maybe 3 sets of 3 or 5 sets of 3. And so managing the volume for that tendon in a way that's really going to get a lot of time or attention across the tendon. I love that. That's super simple to do. People can do it anywhere they have access to the gym. It's easy to grab a dumbbell. It's easy to load up a barbell really quick, push press it overhead, and then control it eccentrically. And then finally, we can never let these folks out the door, especially their first couple of visits, without education on volume management. What they are doing is too much for their current capacity. And so helping these folks modify their programming, especially the old and stiff bucket, these tend to be guys who have been doing this a while. They are used to a lot of volume. They have in general a high capacity. It can be tough to tell them, they need to modify and scale things like bench press, push-ups, overhead pressing, handstand push-ups, because they may have been doing them for decades. And so it's tough to say we need to reduce the volume, modify the movement entirely. It can be a little bit of an ego challenge, but it's necessary. At least while the symptoms calm down, we restore the range of motion, and then we reintroduce volume through that newly found range of motion. And in the young and mobile bucket, just encourage them like, hey, when you see handstand push-ups, let's do your PT homework instead, right? Let's do the dip and drive and do your eccentrics. Let's use that time to, yes, strengthen your shoulders, but in a way that you're not going to encounter a lot of volume. Like if you kicked up to the wall and did a bunch of kipping handstand push-ups that we know your shoulder does not have the strength for, right? Encouraging that what you're doing, dumbbell strict press, dumbbell Z press, is getting your shoulders stronger, just like a handstand push-up. No, it does not look as cool, but it's going to help you meet your goal of reducing your pain and improving your strength so you can get back to doing these things without pain. Triceps tendinopathy. Is it real? Yes, but it is very rare. About 4% prevalence of all tendon injuries. You are much more likely, 5 to 6 times more likely to see somebody with an Achilles tendinopathy by comparison. It happens most often in men over the age of 40 who are doing a lot of horizontal and vertical pressing. We do see it in young and mobile individuals, particularly females who are able to use stronger core, stronger legs to bypass weaker delts. The main diagnostic criteria we're looking for is the presence of that olecranon traction spur, especially, again, if that person can't even get into full elbow flexion because of pain. That helps us a lot prognostically. And then treatment looks like reducing pain, improving range of motion so we can load through the full range of motion, and then loading through that full range of motion with a lot of time under tension. Landmine press, push-ups, plank shoulder taps, plank holds, getting people upside down, handstand push-up negatives, push press, push jerk, barbell, dumbbell overhead, control it eccentrically, anything to get the delts and the tricep a lot stronger. I hope this was helpful. I hope you have an awesome Friday. Good luck if you're hitting 25.3 today. If you're going to be at a live course this weekend, have an awesome time. Have a great weekend. Have a great Friday. Bye, everybody.